Hudzaifah is currently involved in the clinical and also research focus on the anterior segment, especially in the cataract and also refractive surgery. He's also one of the principal investigator for grant-funded studies utilizing the swab source OCT for the ocular parameter evaluation, and also involved in supervising Master of Science student, and also had published few other publication related to the ophthalmology, whether as the main contributor or main author or as the co-author. So other than that, Dr. Joseph also involved in other study related with the optic neuritis under the supervision of Prof. Dr. Wan Hazaba from USM, and also have an active role as the clinical advisor for Clinic Anda Group, in which that he offered the teleconsultation service in ophthalmology since 2023. Without further ado, I would like to invite Dr. Hudzaifah to present his topic. Thank you very much.
Thank you very much, Dr. Syafi, for the kind introduction. Welcome everyone to this second session of UniSZA Ophthalmology webinar series, organized by UniSZA Ophthalmology and with under supervision of Associate Professor Dr. Khairidzan, with good collaboration with IIUM, UCSI Hospital and Rumah Sakit Mata Undaan Indonesia. So it's not too late to wish everyone happy Hari Raya Idul Fitri, Maaf Zahir dan Batin. So let's move on to the main agenda for tonight. Can we see the slide, Dr. Syafi?
Yeah, yes.
Okay. Okay, Bismillahirrahmanirrahim. Welcome everyone, especially all the emerging ophthalmology, emerging eye surgeons joining in to this webinar series. Tonight we'll be discussing about the defocus curve and a better understanding of intraocular lens property. So within this 45 minutes of time, we only will touch on 3 key points regarding defocus curve. Only 3, not more, not less. But by the end of this session, we aim that everyone understands these 3 key points, and finally we'll be able to understand well about the defocus curve, especially in understanding the intraocular lens property. We will discuss about the background, fundamental concept, and a bit of clinical application of the defocus curve. So the first thing is, as a background, in the normal emmetropic phakic eyes, in the healthy eyes with no refractive error at all, so these eyes are able to see clearly at all range. This is due to the accommodation of the crystalline lens. So image stays in focus at the fovea in all range of vision, whether it is distance, intermediate, or even at near. So everything is always in focus. This is due to the ability of the crystalline lens to modulate its refractive power. So the lens has the ability to modulate its power. That's why we can see at all range of vision. So in case of a normal crystalline lens, a far away object will always fall on the fovea. When there is an intermediate, the lens will be a bit thickened. Image will stay at the fovea. And when the image is at near, the lens will be very thick to refract the light so that it stays in focus to the fovea. So in case of a pseudophakic eyes, when you have no more crystalline lens and you implanted the intraocular lens inside the patient, there's no more accommodation. So accommodation is lost. So range of clear vision currently depends on the focal zone provided by the intraocular lens. So now the range of vision is only provided by the IOLs. So in case of a monofocal lens, at distance, you will have a clear vision. But in case of intermediate vision, you will have a poor vision. And in case of near, you also will have a poor vision. For example, if you implant an EDOF lens, so you will have a good vision at far, you will have a good vision at intermediate. However, you will have a poor vision at near. How about monofocal plus? You will have a good vision at far, somehow good or a bit better at between far and intermediate, and then you will have a poor intermediate and poor near vision. And then in case of multifocal IOLs, you will have a good clear vision at far, clear vision at intermediate, and clear vision at near. All this range of vision is provided depends on the property of the intraocular lens. So with these emerging multiple types of intraocular lens in the market, there is a need for a standard tool. So that we need to have a standard tool to understand this range of focus provided by the intraocular lens. So this tool needs to be able to describe the ability of the intraocular lens in order to provide range of clear vision. And we can compare and contrast with different intraocular lens types available in the market. So with this tool, we can compare each of the property of the lenses in the market. Then we understand the behavior of the intraocular lens before we implant the lens to the patient. So this tool will differentiate whether is this really a monofocal plus? Is this really an EDOF? Is this really a monofocal lens? It is really multifocal, or even some described as multifocal EDOF lens. Okay, that's a bit of background. Let's move to the second point for today's presentation. We will talk about the fundamental concept of defocus curve. So we will dive into the basics of it. So before we understand the topic, we have to understand the basic of it first. So this fundamental concept is required because we need to have a tool to describe the intraocular lens focal zone. So we know which IOL will provide which zone of focus. So this tool also need to be able to define the range of clear vision provided by the lens. So in case of a crystalline lens, in case of the patient without any intraocular lens, patient has a natural crystalline lens, we already have that tool, which is the amplitude of accommodation. However, for intraocular lens, we require a defocus curve because it is proven that defocus curve is a good representation of the functional amplitude of accommodation in case of patient with intraocular lens. Patient with normal crystalline lens, however, defocus curve shown to have a good representation of a functional amplitude of accommodation as if we are studying the crystalline lens. So it is a comparable tool. So we will talk about these two for tonight. Let's start with the first one. The crystalline lens. For us to measure the ability of the crystalline lens to providing the range of clear vision, we need to understand the amplitude of accommodation first. What is amplitude of accommodation? So amplitude of accommodation is basically the difference in dioptric power between when the eye is fully accommodated, when the eye is at maximum accommodation, versus the eye at rest, when there is no more accommodation at all. So from this dioptric power, we can understand the range of refractive power of the lens so that the image will stay focused at the fovea at all times. So the formula is, this is the basic formula for amplitude of accommodation. Please bear with me. We have to understand the amplitude of accommodation first before we move on to the defocus curve. So the amplitude of accommodation is calculated by A equals to P minus R. P equals to the nearest point of image and R is the furthest point of the image. From there, we can get the amplitude of accommodation of that patient. So the nearest point is the closest distance patient is able to read, and the furthest point is always at infinity or 6 meters and further away. So if we see at this diagram, the furthest away is when the image falls on the retina without any accommodation. So this is where we say the image is from the infinity. And the near point is when the image is the closest to the eye, so that the eye is at the maximum accommodation. So the lens is at its maximum thickness, and it can still focus the image onto the fovea. This is the near point. So from here, we can get the amplitude of accommodation. How? By this formula. We need to understand and remember this formula from now on so that we can understand the defocus curve. dioptric power is equal to 1 over focus distance in unit of meter. So if you look back at this image, the far point is 1 over infinity. So the dioptric power is 0. There's no accommodation. So power is 0. But at near, for example, in this case, the distance is 0.1 meter. So the near point is 1 over 0.1. So the power of the lens at this point is 10 diopter. So the difference between these two is A equals to P minus R. P is 10 and R is 0. So A is equal to 10. So the amplitude of accommodation for this gentleman is 10 diopters. That's how we measure the amplitude of the accommodation in case of a crystalline lens. Another option that we always use in the clinical setting is we use the push-up technique using the RAF ruler. So we bring the target closer to the eye until the eye cannot read anymore. That's the distance of the near point, so that we can convert and we get the amplitude of accommodation. So in case of young patient will have a very good amplitude of accommodation. In case of an elderly patient with presbyopia, patient will have poor amplitude of accommodation because of poor near vision. All right. We have talked about the amplitude of accommodation. Now we move on to the defocus curve. So to understand the ability of the lens to provide the clear vision, we need to understand the defocus curve. What is defocus curve? So defocus curve is basically a plot of visual acuity against successive lens-induced defocus. So I will explain later. Maybe in the beginning you will think that it is a bit difficult, but bear with me. Everything will be easy after we explain everything. So this plot of visual acuity is measured when we put in the minus lens, or we induce the defocus in the patient, so that we can measure the visual acuity at different distance objectively. So we use a minus lens technique. Just now it was a push-up technique, right, for amplitude of accommodation. Now for defocus curve, we use a minus lens technique. How do we do it? We put a minus lens, put on the patient's striate frame, and progressively increase its minus power. For example, we start with, minus 0.5, we increase with minus 1, and then we check patient's vision. We put on minus 1.5, and then we check vision. And then we plot the visual acuity against this progressive minus lens. So how does minus lens work? So this is very important. So if we see in the phakic patient with a crystalline lens, if we put in the minus lens, it will induce a defocus. Why? Because minus lens will cause the image to fall at the back of the retina. So this will activate patient's accommodation in case of a phakic patient. So whenever you are a phakic patient, when you put on minus lens, it will activate the accommodation so that the lens will be swollen and try to focus the image onto the fovea. This is in case of phakic patient, okay? How about in case of pseudo-phakic patient? When you put in the minus lens onto a pseudo-phakic patient, this will induce near vision. How? By bringing the target image nearer. By putting a minus lens, you are basically bringing the image nearer to you. I'll show you later, but this is the point that I want to stress on. So by putting a progressive minus lens, we are basically bringing the image closer to us so that we can assess the vision as if the patient is seeing the image at a different distance. How? Back to the basic. Diopter is equal to 1 over focus distance in meter. That's the key formula that we have to understand. If we look here, this is the basic refraction that we always study during our first year. So minus lens is basically causing the image to be nearer to you. So it brings the image nearer, and it is called a minification. So basically, if you put in a minus lens, for example, here, you put a minus 0.5, although the object is far away, you are bringing the image nearer to you because of the behavior of minus lens. So the image basically as if the image is brought forward nearer to you. Okay, the higher the power, for example, in this case is minus 1 diopter, the image is further nearer to you and further minified. That's how minus lens works. So basically, by putting a minus lens for the patient, you are one simulating accommodation. You are causing patient as if it is patient is accommodating. The image will bring forward. So we will induce a near vision to the patient, and we bring the image closer, and it is caused a minification of the image. So we can assess the IOL ability to focus at few range of different distance just by putting a minus lens. So for example, if we look at this diagram, this is the image at infinity, right? So we have a patient with intraocular lens. We put an image at infinity here. The moment we put in a minus 0.5 lens, so the image is brought from infinity to 2 meters just by this formula. Okay? By remembering this formula, although the image is at infinity or 6 meters, by putting a minus 0.5 lens, you are bringing the image closer to you. This is a virtual image. The behavior of minus lens is, it is caused a virtual image to become closer and a bit minified, a bit smaller. And if we carry on increasing its minus lens, the image will furthermore closer. Now it's 1 meter. However, it is more smaller compared to before. So by understanding this property of minus lens, we can apply its behavior and we can put into a defocus curve by this lens-induced defocus. So now, this is where the important part is. Let's have a break for a moment, 1 minute. Okay, we have talked about a bit of background regarding intraocular lens and defocus curve and range of clear vision. We have talked about the fundamental concept about the amplitude of accommodation and the defocus curve with minus lens. Now is the time for clinical application. This is where we apply what was our understanding before, and we apply to the clinical practice. So as a recap, the defocus curve is basically a plot of VA against successive lens-induced defocus, right? So plot of visual acuity against successive lens-induced defocus by applying a minus lens technique. So it is an objective measurement of vision at different distances. I think just a reminder, if anyone has a problem with audio, please connect your audio first, so that you can get the audio connection from the session. Okay, let's continue. So by understanding the dioptric power is equal to 1 over focus distance in meter. Okay, this is the basic concept. So if we want to test the clear vision at all range, why don't we just do this? Let's say this is your eye. This is your image, right? So we put the target at infinity first. Okay, we put the target at infinity, and then we plot the visual acuity. For example, this vision is 6 at infinity. And then we just bring the target closer to you. Just get the Snellen chart and then bring to 2 meter now. And then you check the vision at 2 meter. And then you bring the Snellen chart forward more at 1 meter, and then you check the vision. And then you bring the Snellen chart closer to you again at 67 centimeters and plot the vision until you are facing the Snellen chart at 33 centimeters and you plot the vision. For example, for this plot, the closer the target is, the poorer the vision is. Okay. So why don't we just move the target closer to us, right? To assess the vision. There is a problem with it. We cannot just move the target closer to us because it will cause a magnification error, because the size is always the same, but we bring the image closer. So basically the image is become bigger. So the visual acuity at that range, the closer the visual acuity is, the closer the Snellen chart is, the better you can see because the image is bigger. So it is not applicable. So it is not accurate. And then we are basically changing the angle of subtended at the nodal point. This is the basis of visual acuity. We cannot just bring the target closer, but the image is still the same size. And it is cumbersome and very impractical. You need to bring the Snellen all the time closer to the patient just to check the range of clear vision. So this is where minus lens technique comes in. So as a recall, minus lens will simulate accommodation, will induce near vision, can bring the target nearer, the virtual image is closer to you, and it will cause magnification. And we can use this to assess the IOL ability to focus at different range of vision. So in this case, we put the Snellen at infinity, and then we correct the patient with full correction. So basically patient has no power now. Patient has no power and now looking at the target at Snellen chart, patient can see clearly. So we plot the vision here. And then we put in the minus 0.5. So by the formula just now, basically we are bringing the image as if the target is at 2 meters, although the Snellen is always at 6 meters. But when we put in a minus lens, minus 0.5, we are bringing the virtual image closer to us and it becomes a bit smaller. Excuse me. So when the patient reads that vision, it is appropriate for 2 meters. So we plot the vision at 2 meters. And then we put in a minus lens, minus 1. So basically we are as if we are bringing the target at 1 meter now. And the image is smaller. And we assess the vision again. And progressively, we increase the minus power. And we are bringing the image as if closer to us and it becomes minified. And we check the Snellen at as if we are checking at different range of vision. Although the target is always at 6 meters. It's just that when we put in minus lens, we are bringing the virtual image closer to us. So this is where we plot the vision just by putting a minus lens. This is how a defocus curve works. So from there, just by putting a minus power lens, we can assess patient's vision at distance more than 2 meters, for example, at intermediate from 2 meters to 50 cm, and even at near from 50 cm closer to us, just by putting the minus lens and patient does not move at all. Patient is still seeing the Snellen at 6 meters, but just by putting a minus lens progressively, we can assess as if we are bringing the target at different range of vision. Okay, let's take one example, okay? So this is one of the example. This is a graph of a defocus curve of emerging presbyopic patient by age group. So this is a plot of visual acuity. The plot on the left is visual acuity. On the right is the defocus step. So if we remember, along this defocus step, when we put a progressive minus lens, it is as if we are testing at different vision, different distance, right? So this is where it is applicable now. When we put in a minus power lens, we are basically testing at infinity. We put in minus 0.5, we are testing as if the image is at 2 meters, and so on and so forth until minus 3, we are testing at 33 centimeters. So in this case, if we compare different age group, we can see here the line of orange gray, blue, and green. Okay, let's see, comparing different age group, okay? Okay, we see we make a vision of 6.6 as a baseline. So this is logma 0. Basically, this is a perfect vision at 6.6. When you are at 37 to 40 years old, your vision is at least 6.6, even better, from infinity until even at 33 centimeters. So when you are young, your range of vision is basically perfect at all distances until near, until infinity, right? But if you have a progressive age more than 40, now your vision is good at infinity, but until the range of 67 centimeters to 70 centimeters only. After 70 centimeters, after around 60 centimeters, then your vision drop. You have no worse vision less than 660. 6.6. And then the more older you are, the range of vision is getting worse. Now, at 45 years old, you can only see at 67 centimeters, and then your vision is dropping. And then the older you are, at 46 to 48, you can only see good vision from distance until 1 meter only. And then after that, your vision is very bad. This is so far the basic understanding of defocus curve just by comparing different age group. Okay, let's move to one of the example of presbyopic IOL correction lens. So if we see here, the graph on the left, so the same principle that we apply, just looking at the defocus diopter at the y-axis, x-axis, we can just basically understand that this minus power is representing different range of vision. So at 0.5, for example, vision at 2 meters, and so on and so forth. So we see the plot at y is logma vision. Basically, this is where the line is 6.9 for good vision. For example, in this case, they put a 6.9 as a clear vision. So in case of a monofocal IOL, the blue line, monofocal IOL will provide good vision from infinity until 1 meter only. Then the nearer after 1 meter to 67 centimeters, then it start to drop until 25 centimeters. So the lens can only provide good vision at infinity until 1 meter only. Okay. How about EDOF? EDOF lens can provide good vision 6.9 and above from infinity until 2 diopter of minus lens. So it is around 50 centimeters. So this is EDOF property. So EDOF can provide good vision from infinity until 50 centimeters. Similarly, if we see at the right graph here, EDOF can provide clear vision from infinity until 50 centimeters. But in the trifocal IOL, we can see it provides good vision of 6.9 until the 3 diopter of minus lens. So around 33 centimeters. Remember, 1 over 3 is equal to 0.33. So 33 centimeters is where the vision drops. So the lens can provide quite extensive range of vision until 33 centimeters to infinity. Okay, this is the property of trifocal IOL. Now, there is an issue with it. Why? Because the criteria of clear vision is a non-standard criteria. Different brand will provide different criteria for clear vision. Let's have a look. For example, for this case, you can see this plot comparing multifocal IOL and monofocal IOL. Okay, so if we look at the y-axis, we can understand now it is representing the range of vision based on progressive minus lens defocus. So the y-axis is the visual acuity based on logma. So if we decide that the clear vision is at 612, for example, if we say 612 is acceptable for clear vision. So we say 612 is good for clear vision. So for this lens, monofocal can provide a good vision, clear vision from infinity until 67 centimeters. And multifocal IOL can provide a clear vision from infinity until around 25, 26 centimeters. This is when we decide the clear vision is at 612. But if we decide that the clear vision is 66, for example, if we decide that clear vision is actually 66, not 612, so the clear vision provided by these two lenses, for example, in monofocal, can only provide a good vision from infinity until just maybe 3 meters from here. Okay. And then for the multifocal IOL, can only provide a clear vision from infinity until 1 meter only. So the property of the lens or its behavior actually depends on how do we classify the clear vision. So if the brand comes to us and saying that this lens is good, providing a good vision from infinity until, for example, at 50 centimeters, we have to ask that at what vision that you take, what vision or what criteria of clear vision that you take. If the brand comes to us and say we are taking clear vision is 6.9, then we understood, or 6.9 is the acceptable clear vision. Okay. Next is there's also no standard range of distance, intermediate, and near. Some brand will say that intermediate is at 50 centimeters. Some will say at 60 centimeters. Some will say near is at 40. Some will say near is at 30 centimeters. So this range of clear vision depends on what the company say to us. So that's why we have to understand and compare this defocus curve brand to brand so that we understand how they behave. Depends on the standard that we put on. Okay, let's take a look at the real life example that I took from the available material online. Okay, these are all material online just for us to learn today. So let's have a look at the first brand A, with a diffractive multifocal defocus curve. So now the defocus, the brand decide that the distance is at infinity, 6 meters. Intermediate, they decide that intermediate is at 60 cm and the near is at 40 cm is considered near. And they decide the clear vision is 20/20 or 6/6. Okay, 6/6 is the line of clear vision. So by putting a clear vision at 6/6, we can understand that this lens can provide a good vision at infinity until 2 meters. Okay, good vision at infinity until 2 meters based on this defocus. Defocus at the Y plot. Okay. However, moving to intermediate, the vision will be a bit dropped. So patients, when we put in the intraocular lens, this brand A, patients intermediate at 1 meter will be a bit dropped, around maybe 7.5, 6.9, for example. And then when the image is closer to the patient will get 6.6 again. So we understand that for this diffractive multifocal IOL brand, patient will complain a bit of blurry at around 1 meter, 1 meter intermediate vision. But when the patient read at the near vision, patient will have a perfect vision, even at distance, but a bit poor, not poor, a bit low at the intermediate. That's how we understand the defocus that the brand give us. Let's move to the second brand. Okay, so this diffractive multifocal IOL brand, this is brand B versus brand C. Brand B is purple, the brand C is gray. So if we plot the defocus and compare with the range of vision at the y-axis, x-axis here, okay, and we decide that the clear vision now is at 7.5. So this brand says that the clear vision is 7.5. Okay. So the brand B will provide a better vision from infinity, but acceptable vision. It's not acceptable, good vision, 7.5. It's just that distance is better. Even 6/5, the vision at distance. And then a bit deep at the, there's a dip of vision at intermediate, and then improving at near, until provide good vision until 30 centimeters maybe. This is brand B. Comparing to the brand C, if we take 7.5 as clear vision, brand C can only provide clear vision at distance and a bit of intermediate and near. But at 1 meter, patient will complain of a bit of blurry vision comparing to the brand B. So brand C is providing maybe less better vision at intermediate compared to brand B. So that's how we understand the defocus plot, comparing two different brands. But if let's say we decide that clear vision is 6.6, the brand B will provide a good vision at distance and just a good vision at 50 cm. The other visions are lower than 6.6. And if we compare, brand C can only provide good vision at distance only. So it behaves as if it is behaving like a monofocal lens only, if we really decide that the clear vision is at 6.6. Okay. Okay, let's move to the other example. So for example, in this brand A, they compare the monofocal versus EDOF. So, okay, this is the range of vision that is tested. So if we compare the gray line, this is a monofocal lens. If we decide that the clear vision is 6.6, the monofocal lens can provide a good vision at infinity until at 2 meters here. But the EDOF lens can basically provide about the same range of vision, infinity until 2 meters, if we really decide the clear vision of 6.6. But if we decide the clear vision as 6.9, the monofocal can provide a clear vision until 67 centimeters, as if it is behaving as a monofocal plus. So that's why we can hear now, few brands coming to us, they will say that, actually, doctor, our brand is now, we found out that our brand can provide it's not monofocal, it is a monofocal plus, because it can provide a bit of intermediate. Although initially we thought it was a monofocal lens. Just by adjusting the criteria for clear vision. So if the brand decides that the clear vision is 6.9, so they can claim that the monofocal even can have a bit of plus vision. And then for EDOF lens, we can see here, can provide a clear vision at 6.9 from infinity until 50 centimeters. Just barely enough to cover intermediate and close to near. Okay, the vision of 6.9. Okay, I think you have skipped this one because it is comparing of MTF. Okay, let's move to maybe the last example. Okay, this is brand C, but they compare the monofocal and monofocal plus. Okay, so if we decide the clear vision is at 6.6, both lens basically behave the same. They can only provide a good vision at infinity only. Then after that, everything is dipping. But if we decide the clear vision is at 7.5, they can say that monofocal provides a good vision from infinity until 2 meters, and the monofocal plus can provide until 1 meter. Okay, just a bit of range of clear vision just by adjusting the criteria for clear vision. Okay, if they take the clear vision of 6.9, then the monofocal now is behaving like a monofocal plus already. and the monofocal plus is behaving like a EDOF already. So just by understanding this clear vision criteria, we can understand what the market bring to us, and then we can scrutinize and understand well. Lastly, let's talk about the IOL behavior in refractive shift. This is one of the commercial brand. I took this also from the internet. This is the commercial brand of two lenses, brand A and brand B, of a refractive multifocal IOL. So let's say if we implanted the lens with the aim of plano, infinity is no power, zero. So no residual power. Post-op refraction is plano. So at distance, the vision is 6/5. And if we see the simulated image at infinity here, the image is perfectly in focus. Okay? And then at near, patient can have a vision of 6/7, around 6/7. Okay? But if let's say we miss the target of refractive aim, and then we implanted patient and patient had a residual minus 0.5 post-op refraction. So the defocus curve will shift to the right because the infinity now is at minus 0.5. So the focus of all range of focus now is shifting to the right. So now, if we see here, patient is seeing at infinity, now is dropping from 6.5 to 6/7 only. And if we see the simulated image here, the halos will be very bad. Just because of we miss the refractive target of the patient, the lens behave differently. And then we can see here, the vision at near and at distance is around the same, but the distance is lower than when we implant the lens aiming at plano. What about if we miss the target and post-op refraction is plus 0.5? Now, the peak is now moved forward beyond infinity. So the vision at distance now is dropping at 6/7. Worse is vision at near now drops very bad to 0.9. So patient will have a very poor near vision and very unsatisfied just because we missed the target away from the plano target based on this defocus. And we see the simulated image at infinity now. Patient also will complain of halos and glare because of this missed target and the shift of the defocus based on our residual refractive error post-op. Okay, now if we look at the current trend, I think most of us are taught that sometimes we just aim the patient to a bit of minus. For example, in the myopic patient, right? Just aim a bit minus lah, can. So if we look at the defocus, the behavior of the lens, this is a monofocal lens, example. If we aim the patient at plano, patient will get a 7.5 vision at infinity. And the near vision is at 6/24 vision. Around 33 centimeters vision is around 6/24. Sometimes we are taught that we just try to aim minus for the patient so that patient will be happy. So we aim minus, for example, in this case. So the focus now is shifting to the right. Now, the vision at infinity drops to 6/9.5. And the near vision is not increasing that much, just one line only. So we are sacrificing patient's distance and even at near, just because we target patient of -1. Sometimes, by understanding this, we know that post-op, we cannot afford to give patient minus because this lens behave like this, so that patient cannot get perfect vision at distance or even at near. We think that we are giving patient near vision, but actually the near vision is only one line only improving, but we sacrifice the patient's distance vision. So this is one of the key point that we need to understand just by understanding this defocus curve, how the IOL behave and how it will react to different refractive target. Okay, finally, what is the issue of defocus curve? The defocus curve is not standardized. Different brand will bring a different criteria for clear vision. That's what we have discussed before. And there's no standard range for intermediate and near vision. Certain brand will decide the intermediate is what centimeter and near at what centimeter, and there's no standardization. So we have to understand accordingly based on what we know. And certain brand will provide negative defocus, and certain brand will provide also the positive defocus. Positive defocus we will not discuss today. The aim of this session is to understand the defocus curve and minus defocus curve first. Later we can add on about the positive defocus. So that's about it for 3 main points to understand the defocus curve and how the IOL behave. I think that's all for today. I will pass the session back to Dr. Syafi and Dato for comments. Thank you.
Okay, thank you very much, Dr. Hudzaifah, for a very good introduction and also an overview of the defocus curve. I think this is the third or the fourth time I listen to this topic, and each time I listen to this, there's an additional knowledge to this defocus curve. So there's one question from Mr. K. C. Chang. Dr. Hudzaifah, may I know how do you define the clear vision? Is it 6.9 or 6.7.5 and above? Or it depends on the company to decide on that, Dr. Hudzaifah?
Oh, okay, thank you for the question, Mr. Chang. So actually, for the best criteria for clear vision is suggested by one of the publication in JCRS in 2012, the one that I presented. I forgot what's the title. So they suggested that the clear vision should be logma 0, 6.6. 6.6 should be the clear vision criteria, not 6.7.5, not 6.9. But sometimes, if we strictly say that the clear vision is 6.6, then we can see that different brand will, the IOL will suddenly becomes everything just can provide clear vision at infinity only. So the vision at intermediate and poor will be lower than 6.6. So that's why certain brand will come to us and they will put a line saying that we accept the clear vision at 6.7.5. Certain brand will say we accept the vision at 6.9. So from there, they can say that our lens will provide a bit of intermediate, our lens will provide a bit of near. But by standard, the clear vision is always 6.6. Thank you, Mr. Chang.
Okay, thank you, Dr. Hudzaifah. I think by the exercise that you did just now, looking at the defocus curve of multiple comparison of the lens, I think that give
Mm.
an overview, I think good understanding on the defocus curve. As we know that sometimes when the representative from the company coming to us with the new kind of IOL, they will provide you with all this data. And then if we have a bit on idea of the defocus curve, I think we can know the performance of the lens, and not only that, we can compare it for our post-operative result later. I would like to invite Associate Professor Dato Dr Khairidzan for any additional remark or knowledge on this topic.
Thank you so much, Shafi. Thank you, Dr. Hudzaifah. I think the most important thing for everybody to understand is actually the nature of defocus curve. And the reason why this is important now, because almost everybody now claim that their monofocal lens have a plus effect.
Mm.
And that this is where we have an issue before, because the definition keep on changing. You know that we have EDOF lens to begin with, and once you have an EDOF lens, and which actually try to give you the intermediate, again the definition of intermediate, as Dr. Hudzaifah presented before, depends on how you define it. And then when we start doing a defocus curve, you can see that even the previous monofocal lens have a bit of intermediate. And again, that it depends on how you define the clear vision on the intermediate. Yeah. So I think the reason why this was discussed here, in the beginning, so that everybody understand when somebody presented to you with the focus curve, at least you can analyze them well. They can always say to you, and we have this, and many times that we have this in the discussion when one company claim that they have the intermediate, the other company said they have the intermediate as well because of that. And when you compare between the two, it's very difficult because sometimes when they presented the data, you do not know how they actually perform that defocus curve. The best way to do it is you do it on your own patient because you have your own setting, you have your own way of doing things, and then you can actually assess. And the way to assess the lens itself, the IOL, they have to correct the refractive error. If you want to assess the performance of the lens, not the performance of the surgery, the way people do the defocus curve is they correct the refractive error first post surgery. Only after they correct with the post surgery residual refractive error, then they start to assess the performance of IOL using the defocus curve. Yeah. So and that's why I think this is good that we understand this. At least now you understand. For example, there's a question: can you compare defocus curve of Ray 1 EMV and IHANS IOL? And that's basically the problem that we have, because if you are given two different data, you do not know how they were tested in two different population.
Yes.
And of course, all these defocus curve, when you look at the way they perform, you can always enhance the way they will perform, whether it's truly at the Snellen chart 6 meter, or they're performing it at the modified Snellen chart with a different contrast sensitivity. So what we practice is actually when somebody said that they have a good defocus curve, almost a flat line, they don't have the camel hump, all that. Usually said, okay, we understand that, but once we do it in the first patient, we will assess them, specifically. Then we actually, be able to actually assess what's going on. And that's, I think, the idea. I think what Dr. Hudzaifah trying to present. Once we understand it totally, anybody come to us about defocus curve, then we know exactly what they're talking about, and we will actually assess them again. Because it might work with some people, and the way they do the focus curve, it might not work within our hand. So I think as a very good when we go very basic, but very important. And the other thing is, defocus curve was not taught in the master's program.
Yeah.
If you actually go to any master's program, they don't talk about the defocus curve, because mainly when you're in the training, they just want you to become a safe surgeon. There's no refractive component. And that's why it's very important when you become a junior specialist or registrar, that you need to know this, because company will come to you and start talking to you about different defocus curve, and they start looking at all the EDOF. First, they will talk about all the trifocal, multifocal, then they talk all the EDOF, and then they comparing between the EDOF. And then if we don't have a firm understanding, we easily become confused. I think that's my take. I think congratulations on a very nice presentation, that you make it easy and make it visualize for everybody to understand.
Yes.
Thank you.
Okay.
Thank you very much, Prof. So, the audience for today, is there any question that you would like to ask to Dr. Hudzaifah or to Prof. Khairidzan? Okay, one question. If you want to test defocus curve for our post-op patient, is it must be at 6 week post-op?
Oh,
Dr. Hudzaifah?
I think depends on what do we want to look for in the patient. If let's say we would really want to know the functional vision of the patient, I would say that maybe 6 weeks to 3 months post-op. 3 months is the most stable one. But for 6 weeks, it's just basically you can get a basic idea how good the patient's vision is at different range of vision. But still depends, like Dato said just now, what do you want to assess from the defocus curve that you want to do for the patient. Are you planning to check the patient's own vision at distance until at near, or you actually want to test the property of the IOL itself behaving in this patient? If we want to test patient's functional behavior, maybe we don't need to correct the vision at infinity first. We just test the vision, all range of vision, binocular or monocular, depends on what we decide. But if we want to we want to determine the behavior of the intraocular lens, by hook or by crook, we need to first do a full correction first, and then we need to test monocular from distance, and then move the minus lens closer to us until we can see how the lens work. I think that's the more important aim that the more important points that is important in this case. We want to test patient's functional vision, or you want to test IOL behavior. Different different aim will determine different tests of defocus curve.
Okay, thank you. Hopefully that answer the question by Dr. Marwan. Another question is by Kenji Hao. Okay, may I ask, does larger area under the curve definitely mean better performance? So this is one of the terminology that we always listen to. Area under the curve. So,
Yes.
Dr. Hudzaifah, would you like to explain on that?
I think the larger area under the curve is basically where the vision is at the cut point of our determined clear vision. So we
Yeah.
have to know the criteria of clear vision first. If let's say we put the clear vision's criteria at 6.9, then everything will be under the curve.
Yeah.
So that lens is better, good performance. But if we put the clear vision at 6.6, the clear vision, the area of clear vision maybe around at infinity, at that double hum like Dato mentioned just now, maybe only at the distance and a bit of near. Intermediate is deep below the line. So the determination of the performance really again depends on where we put the uh, clear vision criteria. Yes.
Yes.
Maybe Dato
I
wants to
think
add.
Prof Khairidzan, any take on
Yeah,
this?
exactly. I think that's the thing. I got AG when people presented the result like that because the area under the curve, if you put the clear vision as 612, because oh, people can still see in better 612, then everything is under the curve.
Yeah.
Yes.
It is actually really where do you limit that curve is very important. And then I think the presentation that Dr. Hudzaifah did is very well on looking at the real clinical data that the company presented to us,
Yes.
and that is very important. And okay, this is two important things. There's two things that you want to know. First, like Dr. Hudzaifah said, whether you are looking at the functional vision by patient, that's one. The other one is you really want to know the IOL performance. This is two different things, right? So when you were given the new lens, this is two different things. And sometimes the surgeon actually when they describe about it, I could not understand when they talk about the defocus curve of the lens, but they did not correct the refractive error. So and that's why it's very clear. I think that's really good in terms of that. Yeah. So the area on the curve depends on the limit that you put. Yep.
Okay. I think from the explanation just now, I think Dr. Huzaifa did really good in explaining on the defocus curve. We do have the x-axis and also the y-axis, and not only that, we also look at the definition of the clear vision. Only then we can know the performance of the intraocular lens. I think that is what we want to highlight for this topic today. Okay, another question is from Mr. Chang. How about contrast sensitivity? Is this taught in master program? Things like modular transfer function, like MTF?
Okay, let me just answer that. Yeah. Okay. I
Dato.
think contrast sensitivity was actually taught, but was not taught really in detail. The modulation transfer function was not taught. The point spread function was not taught. The degree of aberration was not taught. They were taught in optics. I think this is the reason why we have a seminar like this for the upcoming surgeon, because all these things are very important. And Dr. Hudzaifah was talking about the visual acuity assessment without looking at how people manipulate the contrast in that visual acuity, without any looking at crowding, the crowd factor, whether you're only tested with one single alphabet, or you're looking at the ETDRS. So all that are very important, when we actually tested this. So if you ask me, it was actually mentioned, but in detail in the master's program, we're not there yet, because I think refractive was still not actually the major posting in the in our program at the moment. Yeah.
Okay, thank you very much, Prof, for the answer. Another question is from Dr. Kamal. Salam, Dr. Hu. What is your practice of preference for aiming in myopic patient? If we look at defocus curve, we should aim towards emmetropia. So,
Yes, I think I carry the same sentiment with Dato lah with this one. For all patients, I always aim at metro. We have the perception that those who are myopic, we always aim a bit minus, claiming that patient likes, myopic patient likes minus. But if we see the defocus just now, if we target minus to the patient, we actually doing we are not doing a justice to the patient by providing a clear vision at distance or even at near. We thought that we are providing at near, but basically distance is not good. Vision near is also not that good. So better we aim one good vision at distance, and then if near patient requires glasses later, we counsel patient for readers. I think how about Dato? Your comment.
Yeah, I think this is where a lot of differences in your opinion and khilafiyah in terms of surgeon to surgeon. I'm a bit biased on this because it could be the way I was trained, um, um, and then the way that I was taught on how to answer this as well. I was trained by the refractive surgeon, and the refractive surgeon said that in their experience, no myope like to be left, myope, and there's no point of leaving myope, myope, because what they want is amateur, and there's a lot of evidence looking at that. But I think what some people say that if you have to have a refractive error for the patient who actually have, a high myope, if you have to choose the refractive error, you rather leave a bit of myopic in the already myopic patient. I think that is where the argument comes in. When you say, if I have to choose which error do you want to leave, you don't want to give plus, you will give minus a bit. But that is actually if you have to choose, and you have to choose between the two refractive error. But the aim is try to get amateur as much as you can. Again, we are biased about that. I'm biased about it because but a lot of experienced surgeon or share podium actually disagree with that. They said myope, like a bit of myope. And I do not know if you're doing a LASIK, you have patient -10 and you leave them -9. You correct -10 and leave one diopter, or even -0.5 diopter in refractive patient. They never actually appreciate that. Unless you're really targeting them to have monovision, that's different. If not, then again, I have to disclose that that's my bias. Okay, and then I can use Dr. Hudzaifah defocus curve as actually an evidence. Okay,
Okay,
thank you.
thank you very much. So that is the question by Dr. Kamal. Okay, next question is, I asked about contrast sensitivity because it's not been discussed enough. Like when nighttime comes, visual turn bad even though the focus curve is good. It is important for safety reason, especially walking at night. Thank you, Prof. Yeah, that is not the question that is good. Yeah.
Exactly. That's why I said defocus curve is only acuity, but they don't tell you about quality.
Yeah.
Exactly. I mean, that's a nice thing to actually raise out. Mr. Chang, that's really, really good. Okay, thank you.
I think this is also one of the good session because during our master's program, I think what we want to know is we want to perform the surgery and then we look at our outcome. Now this is the time that we want to refine the outcome of our surgery and look whether we achieve what we target, and if we are not achieving what we are targeting, so there's something that we need to analyze and to look for so that you can have a better outcome in the subsequent operation. I think this is very, very important. Thank you very much for the input from both Dr. Hudzaifah and also from Dato Khairidzan. So is there any other question from the participant of this webinar? So, so if not that, I would like to pass to Dr. Hudzaifah to conclude on the topic today.
I think I think we have discussed a lot tonight. I hope it brings a bit of new knowledge to especially among the new emerging surgeons. We know that in the training we are always trained to be a safe doctor. We don't really consider much about the behavior of the intraocular lenses. We don't have that much exposure about the cataract and refractive. But this is the time for us to gather and share the knowledge, and then hopefully we can move forward together in the future, inshallah. Don't forget to join in the subsequent webinar series. We have another 8 sessions coming under supervision of our esteemed Dato Khairidzan. So I think that's about it for tonight. I thank everyone. Thank you, Dato, for all the input and all the support along the way. And thank you, Dr. Syafi, for conducting the session. I think let's end the session today and conclude. Okay. Thank you very much.
Thank you, everybody. Thank you so much, Dr. Zaiwa. Thank you, everybody. Have a good night, everybody. Thank you.
Okay. Have a good night, everyone. Thank you, everyone.